I thought I'd talk a little bit about like the neuromodulation and that part. Dr. Phillips will be able to give you a much better understanding of the science behind it. I can give you guys a bit of more of like my perspective on it so far, and someone who has been using it for the last couple of years, and just kind of the like, well, how I find it as basically a tool more than anything else, right? So as we all know, there's no cure at this time, and but one of the challenges always comes, especially after spinal cord injuries, is things like, for example, in someone myself who has a pretty high cervical injury, issues such as blood pressure regulation, sometimes temperature regulation, and even things such as spasms, it can be a big effect. And at the same time, you're always trying to do your best to prevent further complications, right? And so maintenance becomes an interesting word. It's almost like maintaining your car in a sense. You want it to last as long as possible and not fall apart on you. So that's the kind of the way I've approached when I think about neurorecovery and neuromodulation, and using some of the for example, in my case, the epidural stimulation device, or even other non-invasive stimulation devices that are out there. And Dr. Phillips will talk a little bit about the science behind it, but and kind of some of the studies that they're going to be doing here at the University of Calgary. But what I found was really beneficial, and when I worked with Dr. Phillips on this, was trying to figure out a way to better regulate my blood pressure. It's interesting that blood pressure is something you hardly ever think about, especially that it's being too low. Constantly, we're trying to make sure that it is not too high. And unfortunately, after spinal cord injury, sometimes it can be very low. And the way you end up feeling that is sometimes almost like that you're lightheaded, you kind of feel a little bit nauseated, and you just can't think. It's almost like being in a fog, in a sense. And so what I found was that towards the middle of the day, or sometimes towards the end of the day, that's what was happening. I wasn't able to function, and it didn't allow me to be as interactive with my family, or didn't let me bothered me at work. And what I found is with the stimulation device, that extra stimulation that's occurring, and obviously Dr. Phillips can explain some of the pathways and how that may be occurring, it seems to really alleviate that. For me, if I can run a program that I have that focuses on blood pressure for about an hour a day, it's enough to make it so I don't get lightheaded throughout the day. I'm able to work through it, and just like everyone else, I get tired at the end of the day. Part of it is I'm just old, and that kicks in, but I'm able to be quite functional throughout, and it makes me way more efficient and functional. The other part is, being in a wheelchair for all day, and especially kind of stuck in that position, you can get quite a bit of spasms, right? And they can be a pain in the butt if you're trying to transfer, or if you're doing something. And what I found is with the stimulator being on through the day and night, it allows me to have a little bit better control of that. I can sleep through the night much better. I'm not waking myself up. I find during the day that my spasms are pretty settled. Obviously, by the end of the day, there's a bit of that occurs, just because you do get fatigued. But it can make quite a bit of difference in that sense. So the way I've looked at in terms of neuromodulation has been really about quality of life. Is it a way that can improve what I'm able to do at this time? Would it be great that it could provide significant functional recovery one day? I think definitely, for sure. And I'd said this before, that it's kind of like, I treat it like it's like the flip phone version. And hopefully one day we'll have the iPhone version here, and that will be so much better, right? So we have a little bit of ways to go. The second part of it that's been really helpful is because you're able to send these signals and stimulate muscles that normally you're not able to, it does allow some additional benefit when it comes to rehab. And so, especially when in terms of trying to prevent issues such as pressure sores or contractures, and trying to maintain bone health. So really that maintenance side of things. And what I've found is that it's been helpful for that, because it allows you to do a bit more in rehab than you were able to do before. I know Dr. Phillips will talk more about it, but you do hear on the news about different people taking steps and standing and different parts of that. And obviously take everything with a grain of salt, because there's different levels of injuries and different extent of damage to different spinal cords, right? But it does give you it says a lot of potential for further improvements down the road. But at least in the meantime, I have found that regular ability to be able to do rehab and be able to use those muscles that I can't control on my own has helped, I think, maintain some of that like bone health, prevent some of the complications that can occur with spinal cord injury. So, and obviously there's a lot of different research being done, and different people have found, at least from my discussions with them, different benefits, and a lot of it depending on what kind of tracks are still intact, but also what area is being stimulated. And I think hopefully from that study that Dr. Aaron Phillips will talk about that they're working on, hopefully that will shed some more light on this. If we're still waiting for Dr. If we're waiting for Dr. Phillips, I'm happy to.
No, Aaron has joined us.
Oh, yeah. Perfect.
Yeah, welcome, both of you now. Aaron, did you want to do your own slides, or did you want us to show them?
Yeah, I can share my slides. Thanks, Dr. Gill. I appreciate you speaking today. It's been nice working with you over the past few years, and thanks, Casey, for putting this together and the invitation. There's quite a few folks here, so I thought, I'd really like to make sure that any questions that you guys have, I know neuromodulation is a big topic, but I want to make sure that you guys get your questions answered and have an opportunity for lots of questions, and hopefully can kind of learn a lot, because I think, there's some misconceptions in the space, but, and it's also a lot of energy surrounding this space right now, and enthusiasm for this as a potential therapy. So, make sure you're asking questions. Don't be shy, and it'd be great if it was a little interactive. Can see that okay? Just the slide? Oh, great. Yeah, so I'm going to talk about one specific aspect of neuromodulation today, that being kind of the cardiovascular system, the autonomic system. We're not going to talk too much about volitional motor movements, so legs moving, but there has been a lot of work in this space, and happy to field questions on that. Very aware of the research in that space, the mechanisms, how it works, but we have limited time. So I thought I would focus on kind of my main interest, which is kind of restoring the autonomic nervous system, those unconscious bodily functions, and in this talk, particularly cardiovascular control. Just some disclosures, we do have some patents in this space, and we've been working with the company Onward Medical to really bring it forward. As probably most of you know, you really need commercial partners in order to bring these types of things into the community. Someone has to take a risk and invest the money in order to have the clinical trials run, in order for this to be indicated as a therapy. So that's why really we're working with some of the major companies to bring this therapy forward, because without them, there's really not a lot of opportunity for us to have this indicated and brought forward. So this is, the spinal cord injury. You see that big injury there, and this is kind of what we study. Many of you may have this condition, many may not. It really depends on the injury level and severity. But this is an example of what's called orthostatic hypotension. This is me taking an ultrasound in the subacute rehab area of GF Strong Hospital in Vancouver, and we're just trying to tilt someone upright, and blood pressure is rapidly dropping from, a healthy blood pressure about 85 millimeters of mercury to a level that you and I would never have. So this individual was losing consciousness, and actually the eyes were rolling back into the head, and we had to quickly move them back into the flat position, which we call supine. So you can see how this would permeate into a lot of different aspects of life. It's challenging to do your rehab if you can't get out of bed. It's challenging to almost do anything if you really don't have stable blood pressure. So what is blood pressure? I mean, movement is kind of easy to describe, but blood pressure is kind of this nuanced thing. It's another one of these ideas that we tend to take for granted, right? We don't really think about our blood pressure on a daily basis, but we do suffer the consequences, whether or not we're aware of it. So blood pressure is defined as the pressure exerted on blood vessel walls. And you have this kind of pulse. So each time the heart's beating, and that's what's on the right-hand side, a heart beating and pulsing out blood pressure, blood flow. And you have your systolic number and your diastolic number, your high and your low, and that's kind of what your doctor reads out at your doctor's office. 120/80 is perfect. You don't want to go too high or too low from that. And why is blood pressure important? This is kind of a fun slide, but also pretty dark, but it describes why blood pressure is so important. And this is an old study from 1941. And you may think, based on kind of what you're looking at and the year, that it took place in Germany or something, but it actually took place in Minnesota. And this was, they did this experiment on a series of prison inmates, and someone conceived of this interesting device, and these pipes here, these tubes rapidly inflate this cuff around the neck, and they cut off blood flow to the central nervous system in 1 beat. And it was some research assistant's job to sit there with a timer and record what all was happening to the person and watch them. And so they were saying, 5 seconds, maybe eyes closed, 10 seconds, eyes roll back, 20 seconds, lost consciousness, 40 seconds. They had this dark term in the paper, irreversible neuronal death, meaning that they didn't come back the same. The brain and the central nervous system is very limited in terms of how long it can sustain low blood flow. And this is a good example of why we need to manage blood pressure and blood flow, and it can't get too low. Here we have, well, I'm not going to get into this whatsoever, but I wanted to highlight how complicated what we're trying to do is. We're really trying to recapitulate and reactivate a portion of your nervous system that's disconnected now from the brainstem and from the areas that are meant to control it up here. These are where a lot of the pathways are down the spinal cord that are responsible for controlling blood pressure, blood flow. And that's part of your sympathetic nervous system. And so what happens after a spinal cord injury, I'll demonstrate on this slide here. This is kind of a cartoon of your nervous system, and it interacts with your cardiovascular system. But what really is happening here is you have a mechanism in your body that senses blood pressure, and these are inside the arteries of your carotid artery and in the aorta. So right as it comes out of the heart, so you have 2 locations where your body is sensing your blood pressure on a beat by beat basis. So every heartbeat, it's detecting it and sending a signal to the brainstem, which is then trying to integrate that information with other things. How emotionally activated is this person exercising? What altitude are they at? It's integrating it with all this other information. And then it decides on a signal that travels down the spinal cord and tells the blood vessels how much to constrict in order to maintain blood pressure at what it should be appropriately. And it tells them to constrict. After a spinal cord injury, this descending, they call it, pathway is broken. So, someone sits up, or someone is getting a tilt table test, or even we see it a lot after meals, what's called postprandial hypotension, postprandial low blood pressure. The signal from the brainstem to elevate blood pressure and stabilize it is disrupted. And this leads to hypotension. And also, many of you probably know that in the acute phase, so very early after spinal cord injury, there is a significant issue surrounding low blood pressure where the spinal cord is not healing. It's got very low pressure through the injury site due to very low blood pressure, which is called neurogenic shock. And people this is a figure that is just kind of describing the issue, but people that don't have their blood pressure stabilized, it goes too low during that acute phase of injury, they have far less likelihood statistically to have the best healing of their spinal cord. And we call those conversions. You're converting to a better injury state. So it's healing more. And it doesn't heal as well when blood pressure is too low. Very challenging to maintain targets. There's some approaches for it, but they're not very effective, and they rely on slow acting drugs. So it's not the best. So, in the chronic phase, and we have a lot of papers coming out in this field, people that have low blood pressure, it's very well established. These are just a few of their manuscripts, but
there's more of those bags, do you think? Are there any more of those biohazard bags? I'm gonna go.
There's a lot of these. papers, and it leads to stroke, heart disease, cognitive dysfunction, confusion, and syncope or passing out. There's very few effective therapies, and very few people are aware of the condition, and it's not rare. You know, this is happening 11 times per day on average, and up to 28 times per day. So people think this isn't common, or I'm used to it, or this is happening in the background, whether we like it or not. So we had a discovery in 2017 with epidural stimulation. These patients were initially implanted with the epidural stimulators that are pretty popular today. They were originally invented for pain in the 60s, and they started to be implanted in humans. We observed, this is a tilt table test, blood pressure is normal here, and then we tilt the patient up, blood pressure rapidly declines, and then we tilt them back into a flat position and their blood pressure comes back up to normal. We observed that when we turned on our stimulator, blood pressure was pretty well stabilized. Now, the issue was that we weren't sure how it was working. It was only an N of 1. It wasn't working all the time, and it wasn't working in everyone. And these people were implanted with electrical stimulators below, very low on the spinal cord, below where those autonomic circuits are located. So we developed an animal model. We wanted to understand this better and see if we could develop a better therapy for stabilizing blood pressure. And I'll just fire, this is a lot of animal work that I'll just breeze through in the interest of time, but this is showing the injury. We developed an animal model that reduces blood pressure and simulates that hypotensive state. And here you can see very low blood pressure in our spinal cord injured animals. And then we found this important location in the spinal cord here, where we actually stimulated at each different spinal segment in our animals, and we looked at how much blood pressure went up. And we found what we call the hemodynamic hotspot, which is these lower thoracic spinal cord segments, T11, T12, and T13. And these offer us very powerful sites of blood pressure control. So stimulating this area immediately elevates blood pressure and tends to stabilize it. And you can see a little bit on the mechanism for those that are interested. These little guys here are roots. These are the sensory afferent roots from the spinal cord, and that's actually how the electrical current gets into the spinal cord when you're using epidural stimulation. It's not intended, or it's not meant to actually activate these central areas. It's meant, most of the current and most of the activation of the spinal cord comes through these dorsal afferents. I'm happy to talk about that a little bit more. Then we developed a system kind of like the thermostat in your house. So it stabilizes blood pressure based on a set point. We decide what the pressure is, and then we can stabilize it. And then we developed a animal model that in non-human primates, and we showed in the acute setting that that we can stabilize blood pressure. And Casey, do I have a bit of time? I think we were a little like under time. So do I have a bit of time to show this video in a couple more minutes?
Oh yeah, definitely. Go ahead.
Okay. Okay. So this is an animal model. Again, we want to see if it works in that early phase after injury, that acute phase when the spinal cord needs to heal. So here we had, and it was really important because, you know, some of the drugs that people are on during the acute phase of injury actually can inhibit the current getting into the spinal cord. So we use propofol, which you saw there, which is one of the drugs that's classically used for surgeries in humans. We had artificial ventilation, which is also used in the human model. And we had a line to measure blood pressure. We then did a thoracic spinal cord injury. We didn't do a cervical, but this thoracic injury model we've shown leads to the same blood pressure dysfunction that we see in a cervical injury. Then we implanted a custom designed array to just activate, again, those roots of the spinal cord at the hemodynamic hotspot. And then this is the data. So blood pressure drops there. And then in blue is when our stimulator turns on. So you can see every time it turns on, blood pressure is just rapidly able to reach that set point that we've decided using that kind of repurposed thermostat. And it works over and over and over. We can adjust the set point and bring it higher. And then this is some work that we did, which this was an individual, 38 years old, cervical spinal cord injury complete. And this is where this array was implanted, which again was over top of the hemodynamic hotspot, those key segments that could elevate blood pressure. And this individual had very low blood pressure and severe orthostatic hypotension that was kind of negatively affecting their life. And they kind of wanted a solution. So this is some of the results. Here you can see a tilt table test, and blood pressure is rapidly dropping during the tilt table test. And then we turn on some of the features of our epidural stimulation approach, activate those circuits, activate the cardiovascular system, and we're able to stabilize blood pressure. We published this in Nature, and then we just got a contract from the US military to really bring this forward and really customize it, integrate it with other types of stimulators, other types of sensors, and try to really reawaken a big portion of the spinal cord for people after spinal cord injury to get function back across multiple systems: motor, sensory, hemodynamics, even bladder and bowel we're working on now. And then I guess it also, part of this whole journey has led to this, what we're calling the Hemo Trial, which is the first epidural stimulation clinical trial in Canada. And we're recruiting patients now. We've been assessing intake and screening patients for the past couple of months and are booking our first surgery dates now. I'll tell you a little bit about it in a slide or two. But this is what we're working on. I wanted to touch on the safety super quickly, and I thought there might be some questions on this, but we're about to have a paper accepted that says it looks at a series of different events, a series of different, a series of risks, and it went through a lot of literature and a lot of our studies, particularly the one in Minnesota that we're working on, the E-STAND trial with Dr. Darrow. We went through all the adverse events, severe adverse events, and then we compared it to existing literature on using this therapy for pain, which, as I mentioned, it's been around for some 50 years for pain, so they have really good data. And it's also a good bar for us because it's approved for pain. It's clinically approved for pain, and it's utilized clinically for pain. So we found in this paper, which Tom Nightingale was the first author, the safety profile of using this device for spinal cord injury is equal to pain, which is a good thing for us, and is a good thing when we go to regulatory bodies like the FDA or Health Canada. We can discuss that and show them the literature. And this is the clinical trial that we're working on. I'll just highlight here what the details are. It's a very, very unique trial. We'll actually be implanting every patient with 2 arrays. So this is what the arrays look like. And each of these dark spots are electrodes, and they provide electrical current. And we'll be putting one over that hemodynamic hotspot of the spinal cord, the thoracic area. And then we'll be putting one over the lumbar area, which is more for leg movement and volitional movement below the injuries. So these lumbar segments, and this, we're working with Medtronic on this, but this is the design of the study. And there's a huge team of support. Dr. Gill, Dr. Rigsby, Dr. Charbonneau, there's a huge team supporting this. And like I said, we're kind of going, getting started now. So I'd just like to thank everybody for their time, and I'd love any questions and discussions that you'd want to have.
Thank you so much, Aaron and Richie, for your presentation. Richie, did you have anything that you wanted to add before we go to questions?
No, I think questions be a good step.
We do have a few questions in the chat here. I imagine, okay, so we have one question. This is from Dr. Rebecca Charbonneau. Do you envision a time where epidural stimulators would be available on a larger scale for persons following SCI?
Yeah, so we're not too far. I mean, if anyone here is interested, you should follow the company Onward Medical. They're very invested in this. They've got one pivotal trial right now happening for transcutaneous stimulation. And they've got more trials coming down the pipeline. They're very dedicated to bringing spinal cord stimulation to the spinal cord injury community. So they're working with the FDA. They've actually, it's public knowledge now. It's all over LinkedIn and Twitter, but they got breakthrough designation from the FDA, which means kind of they get a fast track through FDA. They also get more attention from the FDA and more support from the FDA. And it's, you know, the FDA breakthrough designation is really important because it, you know, they have to apply for that, all the documents, but it kind of, what it's meant to recognize is therapies that can really make a difference and are going to be a breakthrough for folks. So thanks for the question, Dr. Charbonneau. I do think it's going to happen. I mean, if you asked me 2 years ago, I might have been a little bit more cagey and uncertain, but the way Onward is pushing forward with this, it's seeming like it's really close.
And sorry, Aaron, would you be able to type that company into the chat box if possible?
Yep.
We did have one follow-up question from Dr. Charbonneau. It said, do you think that epidural stimulators could affect both volitional motor control and blood pressure with the same implanted device?
Yes. Thanks again for the question. They do, in fact. So we're finding that this thoracic stimulation, which is where we're implanting for cardiovascular control, it also actually, those spinal segments, because there's a topography, and I know you know this, Dr. Charbonneau, but just for the larger audience, there's a topography of the spinal cord where each spinal segment, T1, T2, is responsible for a specific function. So we found an area, this thoracic area, that controls blood pressure, but it also underlies control of thoracic muscles. So what we're seeing is people are getting a lot more control over their torso. So some better balance. We're seeing people feeling more confident to maybe go for kayak even. We've been seeing, you know, longer time in FES where they're able to be upright longer. So, and then in the same idea, if we move a little bit lower, we can actually have coverage over some of the lumbar roots and get some leg movement while also getting cardiovascular control. So there's a lot of crossover, and that topography, the same segments can be responsible for multiple functions. There's also circuits underlying, you know, bladder and bowel that are covered by some of the same segments too. I hope that answers your question.
We have a few more. What would the implications for long-term follow-up for people using or what would be the implications for long-term follow-up for people using epidural stimulation? And how could this change our current practice as healthcare providers of people with SCI in the community, or even at inpatient rehab?
Sorry, I was kind of chopping in and out there. Is it written down here? Implications for long-term follow-up. So that question one there, and Dr. Gill, please also address this because you have kind of a different experience. Implications are, well, we're not there yet. We're still figuring out that long-term care, right? In terms of clinical practice. In terms of the clinical trials, typically we have to agree to follow people for multiple years. That's what some of the community organizations are suggesting. Now, you know, finances are a zero-sum game, but we are encouraged to follow people as long as possible. Some people have run into battery issues where they need their batteries replaced. That's happening more and more. We found that people they're intended to last 5 years, but if people are using them 24/7, the battery will die faster. It also depends on current and how much energy you're using and how much you need. So there's lots of factors. And we haven't it's not so smooth right now. I know of some situations even in Alberta where people were looking to get implanted, but to get their battery replaced, but they got implanted elsewhere, and trying to figure out like a clinical care pipeline. It's clunky right now. They did end up, I think, get their battery replaced, but it took some time. It took some emails and kind of some surgeons just agreeing to do it. So
it's kind of like, I always say, Aaron, it's almost like pacemakers for cardiacs for the heart, right? It was clunky in the beginning. It took a while. Now it's relatively smooth. We have good long-term follow-up. You can get it adjusted in multiple different places. Like there's a lot of potential to follow that similar model, right? There's no reason down the road. Obviously, this is with Canada, Health Canada approval, and a number of those things, but you could see it if it's a clinically valid device and it can be helpful. Everything else will come after that, just like it does for other models in healthcare as well.
Yeah, I mean, the long-term goal will never be how it is now, but you can imagine how it's a little bit, someone gets implanted in abroad and then they come with a problem here and like, well, how do you have this in? Because we don't do that here. And they're still figuring out a lot of the layers, but everyone, I will say on the positive side, everyone's very proactive. Like they're finding solutions for these people that are in these unique situations. It's just kind of figuring out the pipeline for that. Yeah, and it will get better, more organized and more refined over time. What was the second part of that question? How could this change our current practice as healthcare providers and people in the SCI community? Well, there's a great opportunity here, to be honest. And that's the best thing about it is now, you know, someone that's been injured maybe 20 years, 13 years, now they can maybe go back to rehab and do some things that they have a little bit of that they could maybe get some more of. There's a new window there. There's a new period that there might be some plasticity, et cetera. We're all going to need to there's probably going to need to be a line of folks that are experts with epidural stim that work at some of the rehab facilities that are, and there's models for this in existing healthcare platforms where there's people that are experts at tuning the devices and making sure they're working well. And, you know, those people come into some of the rehab institutes and into the hospital and provide their expertise. So there's actually a lot of opportunity in this space, and we're not reinventing the wheel. There is proof of principle in some of these approaches in order to ensure follow-up care of a neuroprosthetic. Richie, I don't know if you have anything to add there.
Yeah, no, I totally agree with you. I think there's a lot of potential, right? We've seen it in just taking patients from a whole other places, like even something simple, something like common like diabetes, how much that landscape has changed from just having insulin to having multiple medications to now your phone can tell you your blood sugars and you can monitor everything, and technology is getting better and better. There's a lot of potential. The first step, as we've talked about, Aaron, is that really getting the evidence you need to move things forward, right? Because the device has been around for a while.
Fantastic. And I noticed, Aaron, you put in the chat there, if interested in the trial, email. So for the gentleman who's looking, how do I get involved with the trial? Just check the chat box there and there is a contact. You guys probably would have a ton more questions here. I know I could probably bombard you with lots, but we're going to have to say thank you so much for your presentation. Again, all of our presenters today, excellent talks. I'm going to pass it over to Dawn here.